All right, there we go. Is that good? Can everyone see that? I hope they can. Getting much more proficient at Zoom. Anyway, thank you everyone for attending. Thank you for allowing me to speak in English. It would not be pretty if I was trying to speak in another. Well, I could do it in French and I could probably do it in German, but I don't think I could even make an attempt to do it in Russian. It's far beyond anything that I learned when I lived in Europe. So. I'm going to talk to you today about some of the work that we did actually with Beckman-Coulter on the ClearLab 10 color system, just to start off with, and then I'll go into some Kaluza stuff afterwards. I have access to a lot of Kaluza files, as most of you probably do as well. So I'll just give you some of the highlights of what we do. But first, let's have a look at some of the evaluation that we did of the ClearLab 10 color system. So this is the disclaimer to say that I am actually I am a consultant at Beckman-Coulter, but this is my presentation, not Beckman-Coulter's. So feel free to ask me any questions, and I will answer them honestly. We've used this system quite a lot. We obviously did the evaluation of it. We did the pre-analytical validation as well. So we did probably 2 years worth of work before it was actually all the testing that you'll see today was done. So we've been using these tubes a lot, and we actually have our own set of tubes as well that we run of the Duraclone tubes, which we're getting another batch made. They're very, very convenient, and if we don't have any in the lab, I get shot by my lab staff because they're very useful, they're very practical, they sit on the shelf, they don't require any mixing. It's very, very nice. So there we go, next one. So yeah, I mean, what everybody has done for 30 years, 40 years now is have typical reagent preparation. So you take individual antibodies, you titrate, you validate them. We still do this. We still have hundreds of antibodies in our fridge, and for some things that we just don't use very much. And every time we get a new one, we need to revalidate them. And even if you put them in with other antibodies, you need to make sure that they play nicely together. And you need to do it well, and you need to do it properly. Preparation of these can take, I mean, we make cocktails obviously because it's quicker when we're dealing with samples, but I know one of the labs in Canada, they employed one person to make cocktails. So that was their entire job, was to prepare and validate cocktails. So it's a time-consuming process. And individually pipetting antibodies, putting them into a batch, doesn't always mean that they will always work the same way as they do individually. Thankfully, we have very few errors in preparation, but it's a constant source of error. I mean, you're pipetting, making 100 test vial of something that has 10 antibodies in it. You do the math, and it can get to a very, very large amount of money. So if you get it wrong, you can have misinterpretation of your patient samples. That sample that was up before, that's your nightmare type of sample. That's one that has negative for all the markers except for one. And if you get that marker wrong, it means you don't really know what you're dealing with. So especially when you don't have any normal cells in the sample. So the ClearLab system that we used, it works well. It works on the Navios. We used an EX, I think, to do our validation. It works well in almost every hematolymphoid and myeloid malignancy that we ran it on. It obviously has some gaps because it's only meant to really be it's a pretty thorough screening panel, but it obviously can't differentiate some of the subclassifications of non-Hodgkin's lymphoma, and it can't really describe well some malignancies that are obviously rarer. And with everything, I mean, that's, I think, the educational part that we always say is that you can't do it by flow cytometry alone. Even on Saturday, I was in here and we had a myeloid leukemia. It looked like a myeloid leukemia, ran it, and it looked, actually, it was 34 negative, DR negative, and 117 positive. So it went up into the cytogenetics lab, and it came back as negative for 1517. So it actually isn't, the phenotype by flow cytometry looks like APL, but it actually wasn't APL. It was just your garden variety myeloid leukemia, but happened to not express 34 or DR. So I'm sure people have shown you this before, the 10 color design. It's morphed a little bit since what it was in its initial evaluation, but really some of the key things that have changed are well, let's just highlight the things that are actually the same. So there's the CD34 is across all the tubes. So if you do have an acute leukemia, you can that's 34 positive. You can see it in all the tubes, and you can just phenotype it from there. Clues is very useful for that. You just color it one color and just read off the phenotype. The CD45 obviously in it as well, and then in between some of the myeloid markers, there's DR and 13 that are the same. And then, oops, I went too quickly. There's actually a couple of other ones. The CD19 in Pacific Blue. Yeah, you should be able to see my cursor, hopefully. Anyway, so in between the B tube and the M2 tube, which is more the myeloid differentiation tube, you can see here you've got 19 that crosses them as well. And then you have a couple of markers as well, like CD10 between the B tube and the M1 tube. So it allows you to bridge between the tubes, which is something that people are probably very familiar with doing, and was a lot more. You had to do it a lot more when we had a lot less colors. So now that we have a lot more colors, you sort of get away from having to do this. But these tubes allow you to do this quite conveniently here. Some of the things that did change, initially there was CD23 in the B tube, and now the CD200. We only used K2-EDTA in ours, but some of the other sites did ACD and heparin, and it shows no difference, which is what you'd expect, really. It would have been very, very strange to have seen differences between the different tube types when the samples are collected. They're obviously dried down tubes. It's not a liquid format, so they're kind of nice. They're very stable. I think they evaluated them up to 42 degrees. I think it was 42 degrees for months on end, and they still perform the same way. So they handle well in temperature extremes. We should probably do like you guys. We should stick them out in the winter and see if they work after you freeze them a bunch of times. But we're not there yet. It's still very nice here, actually. It's like 21 degrees here. It's very strange. And with everything, yes, you need to, cross-correlate all the findings and flow with other disciplines. The work sequence, that's pretty much standard for people that use Beckman-Coulter instruments. The one thing that is a little bit nicer is to do the compensation, we use beads now, which I really hope people are going that way, because the beads are much more convenient than trying to do things with whole blood or even cytochrome cells. The usual check your alignment with the flow check, and you have to do your compensation after you've set your targets with the flow set beads. But after that, it's monthly. Just you monitor the channels that you're running, and you only actually have to do compensation once a month. We're actually not bound by that. That was more an FDA requirement. I think it's the same for the European Union as well, the CE-IVD mark. But we can sort of monitor it for as long as we can. And we normally do 6 months, and then we check it every day. And then, but if there's anything that happens to the machine, so if there's a fluid exchange or if any sort of maintenance gets done on the machine, we do have to redo our compensation again. And the good thing is with this entire system here, so you have all this stuff down at the bottom here, the panels, the flow set, the flow check, you have control cells, and these control cells are pretty unique. They're a process control, so they go through the exact same process that your samples will. So they're stained, they're lysed and washed. Well, first you have to wash them, I suppose, for the B tube. But yeah, they're stained and lysed exactly the same way that you would do that for an actual patient sample. And they have control values in the data sheet that come with the control cells. There's a normal and an abnormal, and the abnormals, I think, 9-ish, 10% CD34 positive cells in the I think just put into the normal control. So it gives you a good process control. So as far as an actual, for regulatory purposes, it's very nice having something that says, you know, look, this is how my samples would react, and I have this as control material. You can run it day in, day out, and it's actually it's very, very stable. It comes in a standard vial, so I've forgotten how many shots you get out of that, but it lasts quite a long time. The compensation kit, which has been around for quite a while, is a mixture of CD3s, CD4s, and one CD8. I believe the CD8 was because that was all that was available in Chrome Orange. But working with the beads, the positive and the negative beads, it gives you really consistent staining, and it's very quick. It's a 15-minute incubation and then wash once, and they're good to go. The control cells, because they're control cells, they're very stable, and you can, you know, the Clusa C software, which is what we use for this, allows you to plot these and have, you know, your standard Levy-Jennings monitoring time and having control limits. The CVs here, oops, back. The CVs here, I really need my glasses on to read this. They're really good. I mean, the CVs on most of these are less than 3. I think there's maybe 1 or 2 that are over 3, but then they're less than 4. If you look at the percent total gated, it's even less than 1. Sorry, I'm going to get my glasses so I can actually read what I'm doing here. There we go. And this is what they look like. This is the abnormal control. So you can see here, this is the large population of CD34 positive cells here. It kind of falls in that, maybe a little bit higher, but in that myeloblast sort of region. And then the gating is set by actually Beckman-Coulter, and you monitor, really shouldn't do that. You can see, you can monitor all the populations there, and it gives you an accurate reflection of what's being stained and how it performs over time. You can see that the abnormal cells are 34 positive, they're sort of dim 123 as well, and they're 117 positive, but all the other populations you're gating are normal cells. They're monocytes in this tube and granulocytes. So for the other tubes, you obviously monitor some of the B cells. You can see this one here, this is the M2 tube, you do monitor the B cells. Because they are fixed material, the separation is not great, but you can delineate T cells from B cells there. The samples look better than that, but that is a control material. So when you look at normal blood, you can see here, here's the CD19. You can see the separation is much better. I mean, it's Pacific blue. It's never going to be great. That is the curse of Pacific blue. It's an older fluorochrome and is not particularly bright. And in all of these, the colors actually were set. So it makes pattern recognition a lot easier. We use different colors in our lab, but essentially granulocytes are blue, monocytes are green, lymphocytes are red, and in this case, B cells are orange. And I mean, if you use Clusa, you have, how many is it? What is it? 8 by 7. So you have like 56 or even more probably colors that you can choose from. So you can highlight things. The one thing I would always recommend is that you keep things consistent across your tubes. It really does help when you're analyzing different samples. We had a junior member of the lab who went through every single one of our protocols and made sure that things were consistently colored. If you look at bone marrow here, it's some similar picture. Again, these are actually, the colors were set, but we added an extra color on these ones here. So if you look at the 19 positive cells in bone marrow, you get cells that mature from CD10 positive, CD20 negative, and then they mature along the line. CD10 positive, they gradually express CD20. And then after they become pretty well completely mature, they start to lose their CD10, and then they gain their immunoglobulin. So the red ones there, you can see have immunoglobulin, the orange ones do not. And there is a little, if you look here, there's a little subpopulation here of black cells that are 10 positive, 34 positive. And those are actually the brightest 10, and those are the ones that also have no immunoglobulin. So normal bone marrow stains up quite nicely. This is the same sort of analysis that we do when we do MRD samples. If you look at the T tube, you can see here you've got normal expression of T cells, you've got CD4, CD8 cells, all of them express CD5, you get a couple of TNKs. This one actually has quite a lot of NK cells and the usual smearing of CD7, so that variable CD7 expression. And this tube has TCR gamma delta in it, so you can see the very small 1%-ish population of gamma delta T cells. The myeloid tube as well, you can see here we've got more myeloid antigens. You can look at maturation patterns of 16 versus 11B. You have granulocytes here, so you have mature neutrophils and you have eosinophils in here as well. There's also T cell markers here, so if you do have aberrant expression, you can see abnormal cells here that maybe express CD7. You can see here, this is just blood, so what you're seeing here is a little bit of non-specificity. You can see it by the right angles here. And you can see the DIM-DR, oops, wrong way, oops, there we go. The DIM-DR on the 64 and 14 positive cells for the monocytes. And if you look in this bone marrow, you can see the differentiation here. So as you lose CD13, you gain CD16 there. So you see that familiar pattern. You can see here there's a few CD34 positive cells and also DR positive. This doesn't have CD19 in it, so you can't really tell. They could be B cell precursors, or they could be myeloid precursors. So that's what the other M2 tube is for. When you look at blood, you can see basophils with the addition of CD123, which is very nice. It's not the most useful marker all the time, but it does have its usefulness because it is aberrantly expressed in a number of malignancies. It's very, very useful actually in B cell ALL if it's positive, because it's completely aberrant there. This obviously is not. These are just standard basophils here. This is actually a figure from the paper that we wrote that has an awful lot of data in it. It shows staining of things that are, on A is a CLL. Ugh, like a hair trigger for a mouse today. A is a 19.5, that's a CLL. B is actually a B cell ALL. C is a T cell malignancy. D is another T cell malignancy that's actually surface CD3 negative. The other one was CD3 positive, surface CD3 positive. That's the one drawback with the tubes. There is still no cytoplasmic tube. So the complete phenotype and the complete workup will still require some extra reagents that aren't in these tubes. But as far as a standardized set, it's very comprehensive. E and F is actually, let's see what E is. E is, well, yeah, E is a myeloid leukemia. F is as well. And G is a CD34 negative myeloid leukemia, undifferentiated. And then H, I think, is an MDS with a lower level of CD34 in it. So you can do lots of malignancies, and the actual study had to have X number of, all the different types just to prove to everyone that we could actually capture everything that we said, well, everything that Beckman Coulter said that they could. This is one here. This is actually an APL, I believe. Yeah, it's actually DR. These are actually turned out to be negative. This is a confirmed APL. Do I have the 17? No, I don't have the 117. No, that's very interesting. Probably should have put the 117 in there. Anyway, but it is, yeah, it was 123 positive and 117 positive. Very strange case. So the few cases that I have that, just to highlight what we actually did. This is case one. This is a 55-year-old male presented with lymphocytosis that was consistent for more than 3 months. If you run, you can see here he has a lymph count of 14, which is, 3/4 of his white blood cells. He has a pretty good hemoglobin, and he has normal-ish platelets. In case 2 is another 55-year-old male. This one has organomegaly, and he also has a lymphocytosis, not quite as much, just over 50%. A little bit more anemic, hematocrit's fine, and a little less platelets. So if you actually look at these two, they do look, morphologically, they do look very different. The one on the left is doesn't have any clefted cells. The one on the right does. They're obviously taken in different ways, so they look actually a little bit more different. Case 1, you can see here, is 19, DIM 20, CD5 positive, and 200 positive, and expressing lambda light chains. Doesn't express CD10, and the case 2 is the same thing again. It's brighter CD20, it expresses CD5, but it is not CD200 positive. So there's a depending on who you talk to, I think Andy's going to talk to you, and Andy is a very big proponent of CD23. And it's not contentious. I mean, everybody has their own thing, and CD23 is often negative in some and positive. It can be positive in some CLLs, it can be negative in others, and CD200 has the same issues. I think it really comes down to a preference thing with the pathologist, which one you prefer to run. We only run CD200 now. I think Andy runs both. And in the end, you need a molecular lab to be able to tell you with fish if there's actually which one it is definitively. So, oh, I got a couple of highlights in there. So yeah, the brighter CD20, which is kind of nice because sometimes you have to choose markers very, very carefully that you can still delineate dim from normal from bright. If you just look at this one here, so this is dim. There are no normal cells, unfortunately, in this one, or not really anyway. And then this is sort of normal to bright CD20. You see a little bit of maybe a little bit of bleed through here. The lambda is a little bit bright here, so maybe that's a little bit compensation here. That's pushing that CD10 up because they're not CD10 positive. But like with everything, compensation is not perfect for every single sample. So you do have to evaluate every sample on its own merit. Another case of a 70, there's a lot of men in these ones. A 70-year-old male presented with palpitations, bruising, and circulating blasts. So that's generally what happens with us, where like this in my office here, the hematology lab is 2 feet that way, and the flow lab is 3 feet that way. So everything comes across from one side to the other. And so if they see peripheral blast, they bring it into the flow lab. And this is the kind of thing that you might see. Circulating blasts, they're extremely fine chromatin, they're large. They are, well, there's actually a fair number of platelets in that one, but there we go, there's a bit bigger picture there. You can see they're very fine. Presence of a couple of nucleoli in there as well. So what you have a very large blast population in that dim CD45 region that expresses CD19. This is a 34 positive one. A precursor cell you'd expect to express high levels of CD38, but a precursor B cell you'd expect to be CD10 positive. And in this case, this is not a CD10 positive B acute lymphoblastic leukemia. It doesn't express CD5 either, and it doesn't express any immunoglobulins, which obviously is one of the things that you need to be an immature B cell neoplasm. And this one does express CD123. So you can see it's quite useful. This would actually be very useful to monitor for after treatment, because CD10 negative, CD5 negative samples are extremely hard to monitor, because you can see here, I'm trying not to click on anything, you can see here that the 19 is a little bit dimmer, and the dimmer it gets, the closer it gets to the T cells. So what you don't want to happen is you to go into the T cells here, because they also don't express, well, they express some CD5, but if you get anything that's, you know, an NK cell, it won't express CD5. They will express CD5 as well, but all you need is to go into here too much, and suddenly you're getting into this T cell region here, which is a real mess. What else did we run? Case 4 is another 34-year-old, another male, 32, with circulating blast, a lot of circulating blast. We had the advantage of having all these tubes, and we ran them in parallel. We kind of did that, which gave us a whole validation of all of these tubes. You don't have to do that, I believe. I believe they're licensed that you can just pick them off, you can buy them off the shelf, which is kind of nice. But it is nice to actually run these in parallel with what you run normally. You can see here the leukocytosis. There's massive amounts of cells on the smear. And again, there are actually very small amounts of cytoplasm in these. The chromatin is very, very fine. That's just artifact. Those aren't actually platelets on it, because I believe the patient, yeah, 24 platelets. The patient is very thrombocytopenic. I mean, the part that you always leave out is that these often present with thymic masses. So this patient did have a large mass. But you can see here, they're surface CD3 negative. You've got a few normal T cells in here. DIMR5, surface 3 negative, expressing 2 and very homogeneous 7. Don't express 16 or DR. Variable CD4 and CD8, DIM, I think is what we probably called that one. And this is a CD3, 34 positive one, and co-expresses CD10. So a myeloid marker on, or B myeloid marker on a T cell. So not that you didn't need to know that that wasn't abnormal, but now you have a useful marker for tracking these cells. I mean, it's not licensed to do it, but we've done a little bit of work with using these sort of off-label and looking at running the cells, because it normally collects 50,000 events, as I think is what the stop is set at. But if you count more events, you can go down lower. It was set at 1%, I think, the threshold. But if you count more events, you can obviously go a little bit lower. These sorts of, you know, very aberrant phenotypes make it easy to distinguish normal from abnormal. So you're looking for a T cell that doesn't express surface 3, but expresses other T cell antigens and CD10. So it makes it easier to find. Another 20-year-old male, relatively normal. This one is at least off from the white cell. Whoops, from the white cell count. Low hemoglobin, very low platelets. This is one that has a mediastinal mass. So depending on how they present, it's normally a progression thing. If they're going to get that far, they present with the previous case with a high white count. This one actually hasn't got there yet. So they're a bit more complicated with what you do with them, because they're sometimes difficult to sedate and difficult to get a sample on, because it's pushing down quite hard on their heart and their lungs. The lymph node, this is a cytospin, so you can see clumps of dark blue cells, very small amount of cytoplasm here. You can see the clustering here. You're almost getting no cytoplasm that you can see in there. This one is a completely 3 negative tumor as well, but this one's CD34 negative. CD34 pushes out a little bit, and that happens sometimes in the with the tissue samples. You can see here, if you run the B tube, we ran all the tubes on them. Whether you need to run all the tubes on every single sample as part of a study, you do that. Whether you would actually do that for something that you have more of a clinical indication that it's going to be a lymphoid versus a myeloid, that's sort of an institutional thing here. You can see here that there's dim CD2 and CD5 compared to the blue normals here. So when you highlight you've got to stop doing that. When you highlight the normal cells in blue there, in light blue, you can see relative expression. So it's kind of nice to be able to highlight the normal. I I didn't on this one, because you can see the 34 here is on top of it, but normally I highlight the minor population, which is normal on top, so you can see where the ratio, what you're looking at, dim to bright. And obviously this doesn't express kappa lambda, but it's nice to see sometimes what's going on with the, that you have some normal B cells within the sample. I think this is almost the second last one. I'm going quite quickly. Given it's the end of the day, it's probably not a bad thing for everyone to go a little quicker. So this is a 60-year-old male again. I think there's one female example at the end. Presented with severe anemia, 65, that's definitely transfusible, hematocrit at 20, and thrombocytopenic as well. Lots of blasts within the blood. This is kind of the day-to-day what sort of seems to happen. Obviously neutropenic as well, but normal level of lymphocytes. These ones you obviously see, oh, but was this a bone marrow? Yeah, this is the bone marrow. So you can see there's a predominance of myeloid cells in this one here. You do have some maturation, so you've got some mature neutrophils in here, but you've got sort of the predominance of these large, relatively uniform cells within the sample here. Some of them are a little bit bigger, but you've got kind of an absence of maturation right here. And here they are, large things, a little bit of granulation, got some nice pink granules on these ones here, and maybe a few basophils, and then more lymph in there. So the same as before, you have a nice dim 45 region. This one's CD34 positive, 10 negative. It doesn't express T or B antigens, which, as far as I was always taught, if it's not a T cell or a B cell, it's myeloid. It's not always the case, but obviously to do this properly, you'd need to run a cytoplasmic tube with cytoplasmic MPO and 3 and 79A, which is, I think, what everyone more or less does to definitively phenotype it. You can see here it doesn't express many, if any, of the T cell antigens or NK antigens there. So it's 34. It does express 13, 33. Oh, it doesn't express 13, sorry. It expresses 38 and 33, and it's also 117 positive and DR. So it's your garden variety acute myeloid leukemia. And last case is a 70-year-old female presented with Pancytopenia. So this is what happens when you have other people running hematology consults. What happened with this one is that someone wanted to run the peripheral blood, and running the peripheral blood won't tell you a thing. So you actually need to have a bone marrow on the patient. And a lot of my time seems to be spent trying to educate people into not doing peripheral blood, not ordering flow cytometry on peripheral blood, because it's a waste of everyone's time. It won't give you very good information. But this one, we did get a bone marrow on the patients because anything on the peripheral blood would have been more or less uninformative. And you can see here, this is what it looks like here. You've got these very fine chromatin, quite blue, but there's almost no granules whatsoever in these cells at all. They're very hard to find because the patient was completely pancytopenic. So extremely bright DR, they're 33, not 13 again. These express 123, so these are yet again an aberrant marker. It's quite common actually, so it is very useful to have. Yeah, these express 117 and 64. This is an NOS. I mean, if you kind of saw the morphology like that, you'd probably think it was a very undifferentiated myeloid leukemia, which it actually does tend to. It flows like that as well. And this is more of the interesting case. So this really is the final one. I know that because it says on my next slide preview. The one thing that you always want to make sure is that you don't miss things that someone else, like you had before. So we have a whole folder full of patients that have one thing and then present with have a bit strange presentation. So Just because you know the patient had something before doesn't mean that you shouldn't investigate it properly. Not that anyone I think would, but running the whole panel does allow you to look at everything. It does highlight a deficiency in the panel here, but it's not meant to be all-encompassing. So, I mean, this patient is a known CLL patient and has a lymphocytosis of, what's that, probably 75% of their white cells. But this time presents with anemia and bone pain. So anemia, sure, that's a bit more non-specific, but bone pain is not really a CLL thing. You see here, you've got clusters of cells, and you've got lots of lymphs in there, which makes sense. You've got a megakaryocyte there. I don't think the patient was particularly, no, the patient was normal, had a normal level of platelets, so nothing too crazy in there. You can see, I'm going to lead everyone around. You can see in some of these cases, there are these cells here, which are, you know, sort of fried egg shaped, you know, that have a little bit of clearing around them. You can see it a bit better here. You've got lymphoid cells, you've got some granulocytes, you've got red cell precursors, and then you've got these other cells that are sticking around here. If you get the morphology before the flow, it's kind of nice, but it can mislead you. And I know there's a fair number of labs. It'd be interesting to know what a lot of you guys do. There's a lot of labs in Canada that do, that's not a lot. There's some labs in Canada that still do a slide and then wait for the slide and then do the flow based on the morphology, which I can sort of understand in some ways, but I have a number of cases where I'm completely wrong with morphology, like completely wrong, like B cell versus myeloid, like, or monocytic versus B cell, or T cell versus B cell. Like, you can get very, very misled with the morphology. This case actually is more interesting because if you see these little fried egg ones, you do start to think more plasma cell neoplasm rather than CLL. So it is useful, and it's not. I mean, we didn't run it this way. It's just an interesting thing to look at after the fact. When you look at the flow cytometry, you can see multiple things in here. Originally, I normally don't highlight this one, but if you do the math, you've got granulocytes here, you've got monocytes, and you've got a lymphoid population, and you do the math, and you end up with 80%. So you've got 20% of your sample that remains unaccounted for. You've got the CLL population here, so you've got the thing that's 200 positive, DIM20, CD5 expressing lambda, light change, and is 19 positive. So you've got that population of CLL still in there. But what you've also got is something that is really, really bright, CD38, which would fit with being a plasmacytic, a plasmacytoid population. To do it properly, you would need CD138, and I don't believe, oh, I didn't display it. I don't believe there was surface immunoglobulin on this one, so you'd need to do that as well. There's a few extra tubes, but this has CD56 and it's CD117, so it does have enough to give you a pretty good phenotype. See, this one here does have maybe a little bit dim 117, and because this was run on a Navios EX, it's actually very sensitive for the 117. We have a number of older Navioses in the EX, and one EX, and the EX that definitely does have a bit more sensitivity on the on that FL3, on that ECD detector, which is kind of nice. We actually used the ClearLab system when we were evaluating it because we had an APL that we couldn't distinguish whether it was 117 positive or negative. And so we had to use the EX, and we used the tubes here. And if you overlay the ECD with a negative marker from one of the tubes and the ECD on the 117, just side versus 117, you can tell it's dim 117. We sent the sample off anyway for FISH because that's the definitive anyway. But and the patient presented in a way that looked like APL, but it was very, very useful. This is a summary. So this is all the work that went into to getting the all of this system approved. So it's non-Hodgkin's lymphoma for the most part, which is mostly what I know most labs see. It's the most predominantly most prevalent sort of disease category that we have. And then we have chronic leukemias, and then acute leukemias being the next largest one. You can see here that there were 4 different sites, and everyone tried to have the same sort of ratios with everything here. So you can see for the most part, it's mostly non-Hodgkin lymphomas, chronic leukemias, and then acutes here. And these were in all different types as well. So, I mean, that's the stats in the end. So that's the diagnostic outcome, which is very misleading. I mean, it's done in such a way that you're trying to evaluate a flow tube versus everything else. So it's a bit unfair, but it's surprisingly good if you think about what else you're trying to do this against. You're doing this against a flow tube, against the flow cytometry that you'd run standard in a lab, plus cytogenetics, molecular, morphology, clinical information, case history, presentation. I didn't do any of the analysis. It was my predecessor, Mike, that did the analysis for this. So you were basically given an age and a gender, and then the flow files. So it's pretty impressive that it does that well, because you'd never use this by themselves. You would actually have to, you'd be given a little bit more information. In the way that most of us work is with a little bit more clinical information. Even a reference lab, you should be able to get more information than what was given for this study. So yeah, surprisingly good for diagnostic outcome. So there's a couple of, obviously false negatives. Some of it depends on how the samples are reported in the individual centers. This is only rated down to 1%. So anything smaller than that, you can't really enumerate. You can say you can detect it, but you probably shouldn't be enumerating it. And some people obviously go really, really low. And T-cell clones are really, really strange. What's an actual abnormal phenotype in a T-cell clone? That's a big discussion that we still have every day. So yeah, the conclusions of this, they're dry, they're very stable, and they're very reliable. We went through 5 lots of these things. The whole system is really nice. It's really slick. It does allow you to monitor and that's really what everyone needs, I think, is a completely standardized way of doing it. So you can set it up the same way that someone else can set it up. These are 4 geographically into like different locations. So, and it goes all the way through. You set it up, you do the conversation, QC, the whole thing all the way. There's a case book as well, which I don't have a hard copy of. I have a PDF of, because it's 578 pages, I think. It's a lot of pages. But it's a great training guide. We have a new staff member starting at the end of the month, and I will give her a copy of that. I don't have a printed copy, otherwise I'd get her to read that. And always the differential diagnosis. You always need to do it with other people. I think there's a few things that we can diagnose by flow. Hairy cell leukemia, there we go. We're really good at that one. Lots of other things, they do require a bit more work, so from other labs. And this is everyone in the lab, past and present. Mike is retired. Ian is Ian is not in the picture. Ian is my medical director, and so is Cyrus. Wendy's retired as well. So we do this, yeah. Retired, moved on to another job, and everyone else is still there. And that's below is our quite large hospital now. In the summer, when it was a lot warmer, but it's pretty good now. Little mini heat wave. If anybody has any questions, they can always email me. I think everyone's got my email contacts at Beckman Coulter everywhere. Have I tried any mathematical analysis? I tried FlowSum, actually. I've tried the stuff that Marie Christine has, which is kind of interesting. That does work quite well. We tend to not do lots of actual mathematical stuff with ours. We do mostly descriptive. I mean, we do some of the we obviously do a little bit of enumeration for certain of our tests, but for the most part, it is descriptive with a population, and we always refer back to the morphology as well. Part of the issue is that as good as flow is, it is a little bit harsh. I mean, we use ammonium chloride as well as same as the system here, and it is a little bit harsh with red cell precursors, so you do tend to lose some stuff that way. So we kind of work, the morphology bench is outside my door, so we tend to correlate everything together with that. Some things, you know, obviously a flow cytometer is better than morphology at looking at differentiating some types of myeloid blasts from erythroid blasts. So yeah, which lysing solution do I prefer? I like ammonium chloride with a fixative. I really do. I mean, it's not the most gentle thing in the world, but it does work quite well. Well, it works very well, really. I've used VersaLyse. Yeah, we did the work for the ClearLab LS, which is a long time ago now. No, that was R2. We developed R2, what, 6 years ago? Yeah, 6-7 years ago. The other one's VersaLyse. VersaLyse works when you okay, it requires energy because of the way that it works. It's enzymatic, so it works really well if you put a bit more energy in with it. So if you can vortex as you add it, it works really, really well, like really well. And because it's enzymatic, it's a little more gentle on things, so it's kind of nice. The only problem with that is that it's not the easiest thing to do, and you can spill your sample and do all of that. The other way to use it is to use it at twice the volume, but that becomes very expensive. Or the other way that I know to use it, which breaks the rule, is to heat it up. And then it works really, really well. But then you've got into like, how do I make sure that I have, you know, enough of the lysing solution that's warm? But yeah, like ammonium chloride, I like. I mean, it's cheap, it works well. I mean, we make our own, but we've used the IOTest 3. For doing our CD4, CD8s, we use the TQ prep. I mean, it obviously wouldn't work with the ClearLab 10-color system, but that's all it's been evaluated with, is ammonium chloride right now. I think there might be plans to push ammonium chloride on the ClearLab LS, but it'll probably work with anything. I mean, it really will. I mean, it depends whether you want to run it as per the manufacturer's guidelines or not. If you run it as per the manufacturer's guidelines, then you have to use ammonium chloride. That's always the caveat. And that's what I always tell everyone. If you need to run it as it was designed, it runs with ammonium chloride. But ammonium chloride is fine. And it's relatively stable. The pH goes off after a little while, so you do have to be a little bit careful. We will only make it in 100 ml batches, so we run it, and then halfway through the day it's finished, and then we have to get another batch out. So, but yeah, it's effective. You just can't over lyse, because then it starts to go all haywire. Yeah, you have to wash. That's fine. Yeah, you have to wash B cell tubes. Whether you have to wash all the other ones, according to the instructions, yes. Realistically, probably not. I mean, you only really have to wash when you have the immunoglobulin there. We wash everything at least once. Anything with immunoglobulins, you have to wash. You have to really wash 3 times. Actually, I wonder if I can find that. I have the data, and we did an experiment for, what was it for? We wrote an article. Oh, I do have that. I know where that is. We wrote an article that was published last year on technical considerations in flow cytometry. No, that was a different one. But anyway, yeah, where we actually did the experiment. It's really, really interesting. If you want to do it at any point, it's you know, not that everybody has lots and lots of time. Oh, there it is. You know, if you want, you can do the experiment where you take something, you don't wash it, you stain it with kappa lambda, and then you wash it once, stain it with kappa lambda twice, and you can just keep going like that. And it's nice having spare reagent. So this was extra reagent we had lying around. It's not the best sample in the world, but you can see what happens here. Like if you don't wash it, and you stain for kappa lambda, you don't get anything. And this is what, like, everyone knows this, but it's interesting doing the experiment. So if you do 1 wash, 2 washes, 3 washes, you get improving signal to noise here. And then we actually do, you can't see at the bottom, there it is. We do 2 washes, we block, and then we do another wash afterwards. And that's what we get. Whether you could do 3 washes or 2 washes, a block and a wash, they're pretty much equivalent. You're getting the same answer both ways. But unfortunately, yes, the requirement is for B cell tubes that you have to wash. It's unfortunately part of the way that it works. The experiments to do some of these things is normally not done by individual labs. But occasionally, to publish things, it's nice to have an example to show people exactly why you need to do this thing. I mean, it's annoying in some ways because you have to, it adds time onto everything that you're doing. 3 washes is an extra 15, almost 20 minutes. So it would be nice to not have to do that, but there is no way around it for the B tube. I'd argue that for the other tubes, you probably just wash once to remove some of the protein and stuff that might interfere with your binding and just clean up the sample, and then you could stain those. That's not the way the IFU is written. The IFU is written that you have to wash everything 3 times. And you do get good results doing that, but I'd argue you'd probably get equally good results for the myeloid tubes the same way. So I'm going to quickly go through this one here, and then I'll flip to Kaluza part the way through. I've used a bunch of analysis tools. I've been lucky enough to be given some of them by people who make them. Out of all the ones that I have used, I actually, this is not by Beckman Coulter, I really like Kaluza. Kaluza is great for clinical labs. A lot of the other software is written predominantly for research people, and it doesn't always mean that it's easier to use. And Beckman Coulter, like Kaluza, really is a very simple analysis software that you can really quickly go through your samples. So I don't want to push it on anyone because it's not cheap, but as far as improved workload goes, I know that in our lab we had XLs, so 4-color analog instruments. Everything needs to be done on the fly, and it spits out paper on a printer. Then we went to an FCU 500 where at least you could do the computation offline, but then you still had to use CXP analysis. So you could at least analyze it, you could tweak the comp if it was off, and then that would still print out. You could make a PDF at least, but the PDF maker crashes occasionally. And then we took the leap, 8 years ago, 8-9 years ago, and we got our first 10-color instrument, and then we switched everything to getting Kaluza. So we had the very first version of Kaluza, and Mike, my former boss, worked with them to make Kaluza, and we've provided input. So we use the red version, so the technically the research one, and we've used that for years. So we're on 2.1.2, I think, or something like that. But we've gone through all the iterations. So we have we've used all of those. I've used FlowJo. I get Woodlist because I know the person that makes Woodlist, and out of all of them, it is the easiest to use because you can use templates, you can drag stuff in. It will run on almost anything. And I know it has these requirements that I think are still a little archaic, that you need to run it on a super fast computer. That's not the case. I have a Surface Book in my bag, and it runs on a Surface Book, and it runs relatively well. Like, you can't open lots of analysis files. If you have a big machine with lots of power, you can open up 100 analysis files, and it will open up really quickly and you'll be able to do them. But you can do everything else quite easily on a standard computer. So all these things, and it is very easy because it is drag and drop, and there's a lot of, once you get to know it, it doesn't take long to actually be quite proficient with it. I mostly go through B cell stuff because B cells really are the majority of what we see. When you look at what it is, you know, we obviously don't do chronic myeloid leukemias, but, you know, acute myeloid leukemias, CLLs, you know, that accounts for more than 50% of what we do. Most of it is lymphomas, it really is, of one way or another. And a lot of them are normal. B cells present the usual way: fever, night sweats, loss of appetite, weight loss, dizziness, and with or without the Pancytopenia, and then, you know, you have the splenomegaly, lymphadenopathy things for obviously lymphomas. So really what we do is we distinguish normal from abnormal. So the Kaluza works really well for doing pattern recognition. That with color, with if you have standardized colors and templates, most of the things are dead space. So you're looking for, you know, things that aren't normal. So if you're looking at 19 positive cells, you know, things that are 1910 shouldn't be there in blood, or if they are in bone marrow, they have a regular pattern. So, you know, in most plots you can gate things such that you have dead space, and if you have gates in there that then pick up things that are abnormal that fall into that dead space, you can investigate them. You don't blindly pick anything that goes into the gate, because that's not good for cytometry, but it really does allow you to just pull things in and then quickly evaluate them. It's not as quick as, you know, a cardiologist reading an EKG, because that's like every 15 seconds they can read one of those. But you'd be surprised at the throughput that you can do with Kaluza and analyzing files. I think for the study we did just batches and batches of them. You get very, very quick at doing these things. So you're just looking for abnormal expression, you know, markers that shouldn't be expressed on your cell, or abnormal levels of them. So, you know, is this, like for B cells, is the 20 brighter or dimmer than what you think? Is there another expression of a T cell marker or a myeloid marker? And then do you have high side scatter, and then, you know, clonality really. So for B cells, it's pretty standard, you know, of this list. Yes, you know, some of these are contained in the CLIA lab, some of them obviously not, and how much you need to do them. FMC7 isn't actually used anymore that much, and we don't do heavy chain expression, you know. So, you know, B cell ALL, pretty standard. You know, you do get some translocations that express myeloid things. And all of the plots you see here are Kaluza, and they're very simply generated. Abnormal is red, really, in these. You have bright CD10, lack of CD40, or dim CD45, and there's a lot of them. And these ones do express myeloid markers. So we do run a whole panel of other things as well, because we're one of the centers that does MRD testing for B cell ALL. This here's a CD10 negative, which is actually a bit of a pain. You have to be really careful here. And this is where choice of fluorochrome really does matter. You have to be careful here that you have things that the markers you choose are particularly well chosen. So CD58 is overexpressed, but it's a very subtle change. This is a CD10 negative one that does express CD38. So the problem with this is you have to be able to distinguish between a plasma cell and an acute leukemia cell here. And CD38, this is actually a bit too bright, so we changed the fluorochrome that we use. We changed it from well, actually, this should be PE-Sci 5.5, and we now use Percy-P-Sci 5.5, which is a little bit dimmer. But plasma cells are very bright 38, so they sit to the right of these ones here. And we run a whole bunch of other markers like CD81 and 73, which help in this case as well. Sometimes you see them, they have bright 19, and sometimes they actually lack CD38. So most precursor B cells, or all precursor B cells, should express higher levels of CD38. So you can find these cells, and using Kaluza really does help you play around with things. The newer versions allow you to do overlays. Oh, I should show you that as well. And lots of other things. So it's the differentiation, the differential diagnosis between what you're looking at. So, you know, you're looking for monotypic expression, you're looking for differential expression of 38s. You have difference in side scatters and different antigen markers. So hopefully, if you do use Kaluza, you use templates. They're very, 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 very useful. There are obviously circumstances where you will use, you will make custom tubes because you have something weird and wonderful and you need to figure out what's going on. But for the most part, everything that we run is a standardized tube. So we have a template to analyze those in Kaluza. We have generic templates for those ones that we have as well, but we also have our standardized protocols. So if we look at one here, you can see here, this is normal bone marrow and this is MDS. You can see here, you've got a drop in side scatter here. So having these plots laid out in this sort of way, you can see the drop in side scatter here, and you can see there's an increase in CD34 in these ones too. But you can see here, having the colors automatically populate here, and then the expression of extra markers here, and you can see here there's extra red cell precursors. You can see there's drop in the side scatter here, and this allows you to look quickly in one go, but it requires pattern recognition, so it requires you to be able to actually know what normal is. So it's not that you can start using analysis software like this and know exactly what it is. That will require experience, but you can see how easy it is to start seeing things that you would expect to see, like when you do get things like myelodysplastic syndrome here. You can see it here as well. You have granulocyte dysplasia here, and you start to see oh yeah, this is Mary Christine's, yeah, which I think she'll talk to you tomorrow about that. I won't give that away. And then if you really want to start doing complicated stuff, then that's where you need to have full-on templates to look at things. These are the antigens that are required. This is for a myeloid MRD. You can see here these are the surface antigens for 3 different tubes here. And then having an analysis template for this is really, really useful. So this is one of our templates. This is our screening tube template. So what we have is we have a template like this that is the same for everything else. All of these colors that you can see on this side here are standardized colors. So we have things that will pick up CLL mantle cells, so they get colored in green. And then we display, and let's start at the beginning. So always run time, always clean up any blips that you have in your sample. We have viability in ours here. You can exclude stuff that dies. So if you do have things that start to drop off and lose their forward scatter and increase their side scatter, you can do that. In combination of these two here, you can clean up your sample no end here. You can see we run with our discriminator set at 100, but we do run our lymphocytes a little bit higher, so we do gather a little bit of debris, but at least we know we're not cutting up the lymphoid cells here. And we kind of backgate here, so you can see that you have a clean population of lymphoid cells. And sometimes you have to be really careful, because if you have CLLs and even some acute leukemias, they can run very, very tiny. So you have to be aware that you're not cutting things off. We have our doublet discrimination gate here, so we just run forward versus forward scatter peak. And then, you know, any doublets would kind of fall up here. This doesn't have that case. I'm actually gonna just get rid of that for a second, so you can see that there. We have a side versus 45 gate. You can see our lysis was okay, but not great. 77% of the sample here lysed. this is ammonium chloride. This should lyse everything. Sometimes you just get red cells that don't lyse particularly well. Ours are colored as such here. You've got granulocytes in purple, monocytes in orange, and the lymphocytes aren't actually colored, but the blue are CD3 positive, and then this reddy brown color are the 19 positive. And because these two are mutually exclusive, we can just separate them out here. So you don't get things that are 19. If you get something that's 19 and 3 positive, you know that it's not real because artifact. Although I think I have a case where I have T and B cell antigens, which I'll show you later. So if you look at all the 19s, these are polytypic, so they express either kappa or lambda. They express either 4 or 8. And then you can see here in this zone here, if there was something that was 19.5 positive, it would populate in here. And this is actually green. And that actually sends to another kappa lambda plot. So if I just drag it down, you can see everything that's here. We have the same thing here for 19 and 10. But we have 56 in here, so we can pick up NK cells and TNK cells. The NK cells are colored in yellow here, and that's the same in all of our tubes. Oh, the nymphs are colored green. So if you have something that's not really being picked up, you can see that it's colored in green. And then we fire all of these to kappa lambda plot. So the 19.5 goes to a kappa lambda plot, and the 19.10 goes to a kappa lambda plot. As with everything, you want to really double check that you're not missing anything. So what I did do is I moved the color off of this one here. Because we have 56 in here, we can pick up things that aberrantly express CD56. So although we don't have CD38 in this tube, we can potentially pick up things that are myeloma or plasma cell neoplasms. This is actually for a testing thing, so I actually played around with Cluser and I digitally diluted the sample. This is what the sample actually had in it, which is 30% plasma cells, which you can see kind of overwhelms everything. Cluser is very nice. One of the things that that Woodlist had for years, which is a way to show things, to increase the resolution, was to make things rare events, and then you can basically highlight them if you've only got a few of the cells in the sample. So if I take this here, these are the NK cells here, and there's not very many of them here, but if I change the resolution, I think I can do this. Show these as rare events. You can see the pixel size increases, which is really nice, so you can actually see the small population without having to play around with the resolution. So yeah, Cluser is very, very useful this way. This is actually a sample that it was a challenge for people. So people were, instead of looking for large populations of cells, they're trying to see if they can find small populations and correctly identify them. So that's an example of a screening tube that it's a screening tube that we use, but it's not really intended to identify plasma cells. We actually would run a myeloid, or we run a myeloid because it was a bone marrow, but we have a myeloma screening tube here, which has CD38 and 138 in it. So that allows us to find this large population of plasma cells that you can see here. And you can see they differentially pick up the viability dyes. So you have to be aware of what you're running. Because if I run it like this, I obviously exclude a large proportion of white plasma cells. Cluser is very nice because you can link gates. So you can see here, both of these gates are linked. This is an ungated plot, and this is a 45 gated plot. The danger is sometimes, especially with plasma cells, is that they have extremely variable CD45. They could fall anywhere within this plot, that you need to be able to correctly identify them. So having this feature where you have the two same plots of 38 versus 138, it allows you to link the boxes so that you actually do not miss anything. And you can see the variation in the side scatter here. These do create a bit of a complicated problem with compensation sometimes if they express very, very bright CD138. This is you can see this is a PC5 antibody. This is something that is left over from not a decade ago, but a number of years ago. And now that we have 10 color instruments, we are actually changing this from a PC5 antibody to something that's compatible with running the red laser, because PC5 and APC do not play well together. For this sample here, we actually ran a cytoplasmic kappa lambda as well. This shows you the utility of having overlays. So if we run, the one tube here has CD38, kappa, 45, and 19. You don't need anything else. You're just trying to find the plasma cells. And the second tube here, oh, that's the second tube. The other tube has CD38, lambda, and 45. So you have the same, you have kappa and lambda, both that you test cytoplasmically on PE. So when you actually look at them, you can overlay the kappa and the lambda because they have the same fluorochrome at the same concentration. And you can determine whether from the cytoplasmic staining, whether they express, in this case, kappa over lambda. And if you look at the normal B cells, you can see there's a kappa or a lambda here. And when you look at the plasma cells, they express predominantly kappa here. And the overlay feature allows you to it allows you here, you can drag, you can see here, this marker and this marker here coincide. So dragging this one over here where you have your normals, you can express your kappa or your lambda, you set your marker based on this one. And you do it for the other tube as well. All right, bear with me, scroll up here, save your kappa and your lambda, and base that on your normal B cells in this sample. And you can see here that they don't express lambda, but they do express kappa. And that's a useful feature. I can't tell you what else other people have as far as the linking goes, but I know this is very, very useful. The ability to go cross between tubes. This is a composite type of feature here. It allows you to do this sort of gating, which is really quite nice because there's no misinterpretation here. You're using the normal B cells here to determine where your midpoint is. And for all of ours, you can see there's tabs at the bottom here. We have a report sheet at the end, and this is what we use. We don't actually we don't print anything anymore. We just generate PDFs. Kaluza does generate very good PDFs. And in the case of things like the next example here, which is Mrd analysis of B-cell ALL, these are extremely large files. These are about 70, 80 megabyte files. This is a glitch in Kaluza, the acquisition and the compensation matrix. It looks strange, but it's artifact. It looks like there's a big step down here, but it generated a lot of discussion. These ones here, you're only looking at B cells. So this is B cell MRD here. You do all the gating. This is actually very simplistic gating, these ones. So all we're doing here is we're looking at all the different plots, and it's purely pattern recognition. So we're looking at the B cells here. We're filtering out anything that's not a B cell. So T cells would probably fall outside here. If I drag this over, you can see where they fall. So you can see you start to get debris in here, and you start to pick up things that are not B cells. The undo function is particularly useful when you make a mistake. And here's the same sort of color coding. So for these tubes, we have mature B cells are always green and plasma cells are always orange. And then the precursor cells are dark blue or light blue, depending on what stage that they're at. The normal pattern recognition is what we use to determine whether they're normal or abnormal. These ones have a normal level of CD10 and abnormal bright CD10 would fall in this region up here. And for these, because they're such large files and we run well, we don't run lots of tubes. We run 2 tubes on them for the most part. We only generate a single PDF. So that Kaluza now is kind of nice because when we select all of them, we can export them and then we just select what sheets we want to create into a single PDF, which is really nice. So we can do lots of stuff like that. Yeah, hopefully people, I know there are still people that do some of their gating on the machines, which depending on the workload gets harder and harder to do. So I think probably one of the best things we ever did was everything's networked, so we can actually move things around. And then we have an analysis room that's next to the lab. So we can actually see everything that's run. All right, so this is a kid that came in that was really, really, really sick. So I actually had to come in and deal with this because I couldn't actually do it at home. You can see here that there's a large population of things that are 34 positive. We ran a lot of things on this sample here. So you got 34 positive, 34 negative, and it's a mass. Let's go to the interesting one here. So we have this. So this is our cytoplasmic tube. So it has, standard tube has MPO, cytoplasmic 3, CD34, 79A, and 45. So it allows you to differentiate T cell from B cell. Because we have a 10-color machine, we can just drop in different markers whenever we need to. This one here is really strange. I mean, it's a thymic mass, so there's B cells in here. there's T cells in here, and then we have this stuff here in black that is expressing 79A and cytoplasmic CD3. It also expresses 56, and it has partial 34. It's not MPO, so we know it's not myeloid. This is really useful to be able to just plot this out and then color coordinate everything between the tubes. You can see here it has dim CD3 on it. It has CD19 on it. And in the end, what it comes down to, it doesn't have immunoglobulin on it, is you're doing a summation of what you're getting off of all of these different tubes. And color coding them in the end was probably the easiest way to actually do it all. Here's our T cell tube here. You can see what they express. So they don't really express CD8, DIM3, no 5, 56, no 57. They express 2 and 7. So it actually turns out to be a T cell lymphoma that expresses B cell antigens. So although you have the CD19 and we have the 19 in multiple tubes, that should be black, make it right for everyone. We have 19 in this tube too, so it has DIM 19. That's the only B cell antigen that it expressed. I don't know how you would do this without some sort of analysis software. It's very, very useful to do using it with Kaluza. The differences between some of these are, like, I'm pretty sure you can have templates for all of them, but the ease at which you can just drag things in, like if I go to our actual main drive right now, I can show you how quick it is to, oh, there we go. If I drag something in here, this is how easy it is to gate things. This is a bone marrow sample with a real gas. A few TNK cells, some normal B cell maturation. You do get some reactivity in bone marrow, so you do get things that are 19.5, which are not clonal. So you can see there's polyclonal cells here. Here you have things that are immature that are beginning to express immunoglobulin. If I actually highlight this region here, it will be red. And if I go along this axis here, so if I could take CD10 positive and I make it more and more mature, you'll actually see this red color start to populate out into either kappa or lambda. So as you see, drag this out here, the cells become more and more. they express, I'm going to show it this way. So you can see them and then they start to express kappa and lambda. So you can see the maturation pattern there. So all things considered, although there's these very high slide scatter things that are 19 here, so maybe I've got something here that is not what I think it is. So you've got to be careful that you don't miss things. So if I get these red ones here, and I just that. Oh, look at that! I've got a clonal kappa population that's high side scatter and 19. So that's probably something like a hairy cell. So there we go. That's the speed at which you can do Kaluza. It doesn't express 5, it doesn't express 10. So yeah, I think we'll be running an extra tube on that patient. Oh, look at that. We have a hairy cell tube. So yeah, hopefully everyone gets the, like, I'm not trying to peddle Kaluza for anyone, but as far as speed goes and what you can do, it really is a game changer as far as what we found. This is a standard hospital computer. It has a nicer hard drive, so it has a solid state hard drive, and it's got a fair chunk of memory with it. Look at that, this patient has hairy cell leukemia. There we go. Standard hairy cell. Yeah, it does work really, really well. As far as the speed at which you can do things and the ability to actually save your stuff. Like people are required, I know a lot of people had difficulty getting rid of paper as far as in our lab. And it's not a generational thing, it's a comfort thing, I think. Getting away from using paper and using the computer, it speeds things up. Getting off of the machine and doing your analysis is really the way that it sort of helps everybody move forward. It's very slick software. It helps you make presentations as well, and whether or not you need to do that or not. But as far as an educational tool goes, you can see that you can teach people very quickly, and you can play around with it. You're not altering the list mode file, so you're not actually changing that actual record. You can play around with the compensation, of course. I mean, if we go back to this, you can. There's Kaluza. If you go back here, I mean, the ability to play with the compensation is quite impressive. You can see here is the compensation matrix for our 10 color system here. Get rid of that. So you can see it's here. You can tweak anything and everything that you want. We do all our compensation when we make the compensation. We actually do it in Kaluza. I mean, you can get rid of the entire comp if you want. You can see how badly our colors bleed over and go all out of whack when we do that. But you could still make things out. You still know this is a CD8 cell, this is a CD4. Obviously, all the color coding is now gone and everything's an NK cell now, I think. But, and you can undo it in a click of a button. I could show you that actually. The one thing that is different that we do that not a lot of other people do is that we do our compensation not on the machine. We do it in Kaluza. It's the same algorithm. So you can see here what it actually does is it opens up. This is making compensation. So this is how the new compensation matrix like acquisition works. So you have control beads here and you have negatives and positives with beads. So it allows you to gate everything and then make an accurate matrix. It obviously has some things that are mathematically done that aren't real, and you can't do negative comp. But you can see here you have nice populations and you gate your beads themselves. Here you have singlets, you have doublets. I mean, they're beads, they do clump a little bit, but I can actually show you how this works. I don't know if anyone's seen this. I drag all the original files in. So we have 10 files in that you do compensation. You have this option. You can make composites, which I showed you before for some of them. You can do prints, you can do stats. We do stats when we do comparisons of lot to lot things. You can merge everything into one, or you can do new compensation. So when you do new compensation, it brings this in. You select what type of compensation you're doing. This is positives and negatives because there are negative beads in this one. And then you say detect controls. And it just goes for the highest peak in each tube. These are labeled so we know which tube is which, but you can see they correspond to the correct one. Chrome orange is FL10, PC7 is FL5, and then you just generate your compensation. The default is in the wrong place, and I don't quite know why, but all the gates are linked. So there we go, compensation done. We run a verify too and tweak the compensation, because although this is very, very close and it is better than some other beads out there, some of the other beads do have a bit of an issue when going from beads to cells. These are different. Everybody's got their own ones. They are slightly different, but we do actually tweak the compensation based on a normal-ish control. The other thing that you can do is you can if you take those same 10 samples and actually merge all of them, you can generate what would look like a digital mix of all your beads, and then you can check your compensation. So this is just a snapshot of some of them, but you can see that the compensation in between all the different plots is perfect, like you would see if you had CD4, CD8 in between everything. You see a little bit of smearing based on the detectors. Obviously, some detectors are not as good as others, so particularly if we do, you can see here FL3 has got a bit of a wobble, and FL4 is a little bit low set. That's how we set up our machines, but you can see there's differences between the ones that you look at. But yeah, there's lots of things that you can do with Kaluza. I think I've touched on almost everything. You obviously do lots of different linked things. I mean, the ability to move all of your, to have your plots that have the same gates in them, to move, normals, and then look at your abnormal population, does allow you to get a little bit better sense of whether things are dim or bright, rather than just using your eyeballs and trying to figure it out. You can get misled. I mean, sometimes it's experience, I know, but the ability to overlay things and move gates now it really does help. So I'm not sure if anyone has any questions or anything that they would like to. Open source software. Ooh, I don't know if there is that much open source software. I mean, there's some people that give you I wonder if the NIH has any. They obviously have some free software. You're paying for the interface, I know. I mean, that's the thing. That's what makes the Kaluza a lot easier to use. But like I said, I know it's not cheap. They're all expensive. Almost all of them are. Open source. Remember what there is out there. There's a few. Some of them depends on what they run. I'm trying to remember what it was. I've used one, I know that. It doesn't work well in the lab. That's the only problem. And I don't know how you would validate that. Yeah, because you can always get 1 month free downloads, but yeah, I'm not sure. There's a few, but it's Profiler. Yeah, sorry, that's a tough one. Maybe the Beckman Coulter people could be really nice to you and give you one dongle, to try it out, get you hooked, make the case for who has the purse strings to be able to give you to get you on. It really does help, though. I know the CXP software comes on the instruments, which is why a lot of people use that. And you can do it. It takes away from running a sample, and it's not designed for that. The CXP on a Navios is CXP from an MFC 500 with 10 up to 10 detectors on it, or 10 fluorescent detectors on it. It's not really designed to do analysis, so it does make your life a lot harder. So I feel bad that if you can't have that as something as an option, it's not nice. But yeah.
But we have a question about using reluctancy for minimal residual disease. What do you think about? Maybe you have some experience.
Yeah, it works well with minimal residual disease. It is all dependent on the computer that you're using. The more powerful the computer, the better the graphics card, the more you can drag in, and the easier it is, because every time you change a gate, and they're not so much all linked, because that's the CXP problem. Like CXP, every time you move a gate or you change a color, it recalculates for every plot. Kaluza doesn't do that, but Kaluza still uses a large amount of energy doing that, and the bi-exponential plot uses a lot more memory. The rare event thing uses a lot more energy. So it's definitely doable. I mean, we do it all the time. It definitely works for doing minimal residual disease, but we have set templates that we use for that. But the files are huge. I mean, if I look at what was the one we had yesterday? Yeah, the combined analysis file was 246 megabytes. That's for one child. They get large very, very quickly. So yeah, you have to have a computer that can cope with that sort of file. Most newer computers are pretty good. Where they fail is the graphics part. So you need a strong enough graphics card to do it. But almost anything will run it. It's just how many you can do at a time. If you drag in more than 20 things and you don't have enough memory, you'll get what I had there, which was a Kaluza exception warning thing come up, and then it crashes your whole system. Well, it crashes Kaluza. You just reopen it and start again. So you get into a way of doing things. You just save everything. Once you drag it all in and do crude analysis, you just save it, so you don't have to start back at 0 again. But the gating is easy enough that you can, I didn't really show any of that, but the way that we normally do is you gate your region of interest, and then you filter it out by sort of doing logic gating. So, your standard way you're looking for, and then you filter it out based on larger gates. So it works well for doing that. The only thing that it doesn't do, which I know, well, I only know Woodlist really well. Woodlist allows you to do calculations across tubes, whereas I can't do that in Kaluza. We have a spreadsheet. That's what Excel does really well. And then it's a record of things. But as far as, extra things that it could do, I mean, a lot of it now is pretty nice, because you can do overlays of dot plots. You can do overlays. You've always been able to do overlays of histograms, but you can do overlays of dot plots, and you can link between things. So yeah, MRD does work with Kaluza, but because the files get so large so quickly, you need enough of a computer. I'm at the limit. Mine is just powerful enough, and the Surface Book is if I ever travel ever again, that's what I would have brought with me was a Surface Book, and I have like an extra dongle, and it works. It really does, which is quite surprising when you think about all the calculations that the software is doing, that it's actually capable of running on basically a tablet. I don't think there's any plans to have it run on OS software or Linux software, which would probably make it a little bit faster. At least the Linux software would make it run really quickly. But yeah, MRD analysis do a lot of that. I think my folder for, I should probably archive this. I think my folder for MRD analysis is, oh wow. I've hit 30 gigabytes already and it's still calculating. Yeah, so yeah, the problem is not doing it, the problem is saving it most of the time. So yeah, that's 150 gigabytes. Yeah, I should archive that somewhere. You have to talk to your IT people very nicely. That's my suggestion for doing lots of Kaluza analysis. It's very, very, very space orientated. So, but yeah, I like it. I mean, I can't say enough. I was really, really lucky. We got the first version of Kaluza when it was research only, and we've been using it ever since. And yeah, it's easy for people to use, and that's my caveat for clinical labs. If you're a research lab, it's really, really different. Like you might have something different that you want, but for a clinical lab, the speed at which you can do things, and you know, with templates, if anybody wants templates, I can quite happily give them templates. Sorry, someone at my door. Yeah, it works really, really well, and I don't know how much it costs. That's how bad it is for me. I'm really, really sorry. It's a great position to be in, but we do have, because we did some of the development work. I have a Kaluza C dongle as well, but they're identical. But and that was for the work that we did with the ClearLab stuff. It's a whole little package, so maybe you should throw it in with every new flow cytometry. You could give people a dongle for Kaluza. That would be nice. So yeah, that's my solution to everything. Get a freebie Kaluza dongle with the purchase of a flow cytometer.